there. In this presentation, I want to discuss three aspects in regards to pain, the endogenous pain modulation, central nervous system, and their clinical implication. First, I want to review endogenous pain modulation and the role of central nervous system. Then I want to explain the connection between the current conceptual paradigm and real patient presentation, and offer insights into strategies for practical application for intervention and management. Before we dive into these, however, it is essential to understand the fact that we hadn't always appreciated how the central nervous system is an active participant in pain experience. In fact, the purpose of this entire presentation is to simply gain more understanding on how the central nervous system is an active participant in pain. The opposite of active participation is passive receiver. Now, we used to think that the role of the brain is simply to receive the nociceptive signal that's been generated peripherally, and that's about it. And unfortunately, there are a number of incorrect beliefs and actions that's risen from that. Now, some of these are: the amount of pain experienced is directly proportional to amount of injury. That's the way the patients believe that more pain means that more harm done, which we all know is incorrect. The source of the pain always lies peripherally. Now, this gets patients and health professionals fixated on x-rays and investigations. And close to that is the last belief: the source of the pain has to be found in order to address the pain, which leads people to excessively looking for where the pain's coming from. The beliefs such as these are easy to understand, and even a lot of health professionals hold them true. And while they don't matter for simpler injuries, because they all get better anyway, when it comes to complex or chronic pain, these beliefs will not help. So let's briefly review how the central nervous system actively participates in pain experience. It participates by modulation and facilitation. This is a continuum of the same concept, so let's just call them modulation for now. I can summarize modulation into four centers. First is segmental, then its lower centers, the higher centers, and hormonal. Segmental is where non-nociceptive afferent stimulation can inhibit ascending nociceptive signals at dorsal horn. This is essentially how you feel better when you rub on a sore spot. Now, when you do, the non-nociceptive A-beta nerve endings are stimulated, and that signal goes into the wide dynamic range neurons at dorsal horn. And then it recruits inhibitory neurons that dampens the nociceptive signal from A delta and C that also enter the wide dynamic neurons as well. Then the lower centers, or brainstem, is responsible for sending pain modulatory signals down the spine. One of the mechanisms that's been identified and is quite well known is descending nociceptive inhibitory control, or DNIC. And this gets triggered when you already have an ongoing nociception. Then a new nociception is stimulated. Then there are other modulatory mechanisms from here as well, and they are all intimately connected to the next bit, which is the higher centers. And this is the bit that makes humans apparently smarter. And this is also where expectations, beliefs, attitudes, and other affective constructs are created and influence pain. They influence pain by directly influencing the lower centers that I've just talked about, particularly periaqueductal gray, resulting in descending modulatory mechanisms. It also understandably has close links with the behavior of the autonomic nervous system, which plays a major role in the last pain modulation center, that's hormonal controls. It's no secret that hormones are incredibly influential when it comes to behavior of our bodies, and and they can have a major impact in pain modulation or facilitation. Some of these hormones that are often mentioned here are noradrenaline, adrenaline, cortisol, and dopamine. While I'd love to say that increase in this hormone increases modulation and increase in that hormone increases facilitation, etc., it is not that simple, and I certainly lack the expertise to go into finer details. Let's put these into the context. We have a 50-year-old patient who comes in with a back and leg pain that he's been having for the last 12 months. He brings an MRI that clearly shows a disc prolapse into the nerve root, and assessment reveals that the leg pain is indeed referred from that. He's been off work for about 10 months and had returned to work about 2 months prior to our initial consultation, and he's pretty nervous and hypervigilant. Now, we know that 12 months out from initial injury, it's unlikely that there is any more healing to be done in regards to the disc. We also know that the mechanisms of his pain is likely to be a mixture of dysfunctional, nociceptive, and possibly still some neuropathic. But we can strongly assume that the dysfunctional mechanisms would form the majority of the pain. And of course, there are a number of ways a clinician can attempt to help the patient resolve this pain, ranging from massage to transforaminal injections. I'm not here to discuss the merits of each interventional methods, so for the purpose of this presentation, let's focus on two things that I personally utilize as a physiotherapist, and they are education and exercise. Education is arguably the most critical first step. It's because the power of pain excitation that's worsening, that comes with the things that are unknown, and equally the power of pain modulation that comes with assurance and knowledge. We have to use the assessment and clinical reasoning to find that unknown that a given patient has been missing and use our communication skills to resolve it as much as possible. When done right, this will shift the perspective at the higher centers of the patient from whatever that's contributing to persistence of the pain to a perspective or belief that'll help to resolve the condition. You are essentially setting up the patient or priming the patient for the intervention and follow through of the interpretation of the patient's condition that you've just given. This might sound obvious, but it's so important. You need to follow through whatever interpretation you've given. If you've told the patient that the reason for his pain is because of chronic stress, you'll need to follow up with the strategies in regards to that. If you've told the patient that the reason for his pain is because of genetic disposition, you'll need to follow up with a strategy and explanation in regards to that so it resolves, and the list goes on. Often, I do come back to something like, look, I don't really know why, but with current scientific evidence, it is possible that, and I offer them some individualized hypotheses and end up with something like, it's actually not crucial for us to know exactly why this condition has started, because the fact is you're right now in pain due to sensitization. So we need to focus on how to facilitate pain modulation from your body, and that can be done without knowing exactly why it might have started in the first place. It is also important for patients to be clarified what their condition is not. For example, in cases of primary pain, the pain's not from arthritis. It's not due to ligament tears. It's not due to disc prolapses. It's amazing on what concepts patients latch and refuses to let go. So they all need to be resolved. After an appropriate education is given, the next step of intervention can be provided. This will be different for different health professionals, of course. And I'm not going to say which one's superior, but what I will say is that the success of the management depends not so much on the choice of intervention or what you do, but the framework on which the intervention is based. And the framework that I would like to advocate is biopsychosocial model with the intention of facilitating endogenous pain modulation. Today, I will use exercise as an example of intervention that I utilize upon the framework. Before we begin exercise, we do need to make our intentions clear. We don't exercise to make this patient stronger, more flexible, or even fitter. That's not why he is here. He is here to improve from his back pain and will achieve that by facilitation of endogenous pain modulation. And just exactly how am I going to facilitate this? The evidence points to a number of methods, and these are isometric contractions, anaerobic exercises, relaxations, and motor control exercises. That's like everything. In fact, there is some level of evidence that exercise of any kind is just as good as any, which I'm not sure if I agree when it comes to a real clinical application, but that's for another day for us to argue about. Anyhow, that's good news because that means most exercises, when done appropriately, has potential to facilitate pain modulation. But today, I'm also wanting to talk about the framework that facilitate pain modulation from the central nervous system, and one of these frameworks, the major one, is graded exposure. The intention behind graded exposure is resolution of conditioned fear that follows a stimulus. And I would like to go a step further and say that it's not only conditioned fear, but conditioned pain experience, one of which is pain facilitation. So my job is to find out how the body is conditioned to facilitate pain under which stimulus, then execute strategies that gradually expose patients to the stimulus and coax the mind and body of the patient in such a way that each step of the gradual exposure is successful. And that's really important, that each step needs to reinforce success. And the definition of success is no aggravation of pain experience or facilitation. In other words, for patients to be able to perform the exercises without pain or with minimal pain. And there are some conflicts in opinions when it comes to pushing through pain or avoiding pain while exercising. To me, I'm firmly in the camp of exercising without pain. For patients, the experience of being able to exercise without aggravating pain is revolutionary. It is a cognitive success that's imperative for adherence and pain modulation. And this power of success, no matter how small, is incredibly significant and will have a lasting effect on pain modulation by higher centers, lower centers, and hormonal aspects. In the case of our patient, he might be struggling with bending forward, and I might have found in his general pattern that his symptoms are stable in neutral spine and small level of extension. Let's think McKenzie for argument's sake. So I will begin exercising in exactly that range where he is comfortable, in neutral spine and with small range of extension. I might begin with non-weight bearing or very simple weight bearing exercises depending on his tolerance. There are two aims to this: muscle recruitment and success. And there will be lots and lots of positive reinforcement and encouragement. I'll also gradually increase the intensity of these exercises by increasing resistance, speed, duration, complexity, and range, or whatever that breeds success, which of course means being able to do the exercises without pain, aggravation, or ideally with total absence of pain. And it is possible, when done right, exercises can actually resolve that constant pain patients often have, most likely due to segmental modulation by stimulation of afferent sensory inputs and activation of higher centers by distraction and task focusing. There also likely is some level of activation of descending modulation from brainstem as well. Of course, I haven't even started to talk about biomechanical effective exercises, but this is not the time for that. And from that point, it's all about gradual exposure to increase the load and difficulty. And we might begin with flexing the spine in non-weight bearing. Then we might do some gentle squats or lunges. We might do some sitting exercises. Then we might do some supported flexion in standing. Then we might even begin running and lifting some heavy weights. And by that stage, along with ample education and encouragement, his struggling with bending forward will have resolved. It is also worth noting the difference in clinical reasoning when it comes to pain modulation compared to traditional biomechanical thinking. In the case of the third exercise here, the flexion in sitting, there is some evidence that produces more load in the spine than the last exercise, the flexion in standing. However, the biomechanical loading when it comes to graded exposure or pain modulation is largely irrelevant. This is more to do with hierarchy of fear. And in this patient, flexion in standing definitely stimulated more fear than flexion in sitting. So that's how the exercise will progress. It's also important to note that there is no such thing as a recommended timeline for progression. It's not like ACL post-op guidelines where you expect the patient to meet the milestones with certain timeline, because this process of pain modulation does not depend on structural healing, but more on manipulation of the higher centers and subsequent pain modulation. The result can be unexpectedly fast or excruciatingly slow. So in order to do this properly, patients often need constant guidance, reassurance, and education. And this will be cognitively taxing for clinicians as well. But that's why pain rehabilitation is exciting and is rewarding. It's a true medical practice of seeing patients as people and not as conditions. And there is a definite art to this, as you have to win the mind of the patient. We've covered a great deal. I've tried to give you an overview, but many of the points that I've made today can be discussed in great depth in their own right. There are some fantastic articles here in my references, especially one by Marchin on physiology of endogenous modulation, Mel's up on the same topic but more general overview, Mosley on pain education, Vliayan on graded exposure, and Varde and Wolf on mechanisms of pain. Anyhow, the take-home points are: pain modulation occurs at segmental level, lower centers, higher centers, and hormonal. Your assessment and intervention should be based on the biopsychosocial framework that aims to positively influence those centers. And graded exposure is often a crucial and very useful platform for management. There are no recipes, no algorithms, no step-by-step guide for pain management. It's application of your knowledge into clinical framework. So you really have to know what you're talking about and then have good skills in your cognitive function to be able to apply it into clinical practice. I hope this presentation has been helpful for you to construct how that can be done in your setting.